Good afternoon. I'm Rick Nelson. Welcome to Indianapolis. We've had great weather. Hope you enjoy the city. It's our stomping grounds. First, I'd like to just have you recognize that on your badge, there's the poll anywhere. So if you take that QR code, start to work on having that uploaded. We have 4 separate questions throughout the talk that we'd like your responses for. So first, I'd also like to thank the ANS and the Education Committee for asking us to present today about basically intracranial hypertension and its impact of the ear. So I'm joined by my esteemed panel, and this is how we're going to sort of go in order and what we're going to discuss. So Esther Vivas is going to talk about symptoms related to intracranial hypertension in the ear. Gerard Gianoli is going to talk about the diagnosis of intracranial hypertension. Graner is joining us from Indiana University. He's our neuroradiologist. He's going to give us some radiographic manifestations. I'll discuss medical management. And then Brad Bohnstedt is a neurosurgeon, neurointerventionalist, who's going to talk about management of the intracranial vasculature for intracranial hypertension. These are our disclosures. Most of them are not relevant today. Each participant will likely re-show these, but these are our disclosures. And this is the first question. As we bring up the first speaker, what is the most common otologic symptom of elevated intracranial hypertension?
Okay, well, thank you for that. It looks like tinnitus is by far the most common choice here. Great. Can we go to my slides, please? There we go. All right, well, thank you so much for having me here today. Idiopathic intracranial hypertension has gone through a variety of different names over time. I did not do that. Let's go back, okay. And there's still literature that's being published under the nomenclature of pseudotumor, for example, or benign intracranial hypertension, and we're trying to stay away from that and defer to the name IIH or elevated intracranial pressures. Now, what's interesting is this was first described by Dr. Dandy in 1937, and this report is his summary of 22 patients that he followed over 7 years. And I want to read the very end of this paragraph because it's very relevant. Now, for historical reference, these patients used to get craniectomies for decompression of their pressure. So they would literally have their dura under the scalp, and you can see the bulging of their brain when the pressures increased. So curiously, the decompression is almost never consistently at its maximum fullness, but is intermittent. And the pressure may come and go with surprising rapidity from one extreme to the other in a few minutes. The cause of the sudden changes, indeed, the cause of the increased pressure at all, is unknown. Unfortunately, there's still unknown, that's unknown in this disease process to this day. So what is the impact? There's a study out of the UK that reported a 442% increase in IIH-related hospitalizations. We know this is much more common in women, particularly during their reproductive years. In essence, this is a problem of the young obese women. And because of its relationship to obesity and the rising obesity rates in the world and in the country, it is a problem that we are going to continue to see over time. And obesity has a linear correlation with intracranial pressures, as you can see in this graph. And because we are unfortunately the number one country. We are the fattest country out there. We are going to see a lot of patients with this problem. The sad little face there is Indiana. So the deeper the red, the higher percentage of obesity in that particular state. So obviously those who live in California or Florida are going to see less of these patients than for those who practice enriching Rick Nelson's practice right here. So obesity is seen as an increasingly, is perceived really as also an inflammatory disease. Cytokines within the adipose tissue are implicated, but there's also been markers of inflammation present in CSF of patients who have IIH. Now, there are several proposed mechanisms out there, and I'm going to review one of them only to illustrate a point. For example, it's thought that the higher the weight, your increased, intrathoracic, intra-abdominal pressures go up, which then increases your central venous pressures, decreases the absorption of CSF, and that leads to elevated intracranial pressures. What's the problem with this? Doesn't explain why it's mostly in women. So there's some sort of hormonal contribution that we yet don't really understand. Now, if we look at the most common symptoms of IH as a group, headache is by far the most common. If we look at it from an eyeglass of an otolaryngologist, we're going to see those patients with headache, pulsatile tinnitus, dizziness, and this is replicated in several studies and reports. Now, if someone were to walk into this room and not know what the topic of this panel was, they're going to look at this slide and say, oh, are you talking about migraine? There's a huge overlap in migraine patients and the otologic manifestations of intracranial pressure that are elevated. We're unable to focus on all of these, but I'm going to review some of these that the more common symptoms listed here. So if we talk about pulsation, this is a patient who presented to me after being treated for an otitis for several months. She had all the symptoms. She had pulsatile tinnitus, she had hearing loss, she had oral fullness, she had ear pain. And of course, the eardrops that she got for multiple months weren't doing anything. She is a patient who ended up being diagnosed with IIH. She became quite symptomatic after we repaired the encephalocele that was filling her middle ear space and ended up with a shunt. So this is a wonderful slide. Why? Because it just illustrates the mental exercise that we have to do and go through when we're working up pulsatile tinnitus. I mean, it's huge. If you look at this list, these are all the things we think about. But if we think about it in the scope of patients who have elevated intracranial pressures, we can narrow it down a little bit. So we're going to do just that. We're going to look at venous anomalies. Now, we know that these patients have diffuse thinning of their skull base, and also they have sigmoid or cerebral sinus anomalies, including anomalies of the sigmoid sinus. It could be either a sigmoid plate dehiscence, it could be true diverticuli, it could be dehiscent jugular bulb. So if you see a patient that's coming to you with headache, pulsations, and they walk into your office kind of pressing their neck like this a little bit, and you're like, what's going on? She's like, Doc, this is the only position where I get a little relief. So unilateral pulsations that respond to neck compression, that should really be a signal that there is probably a venous anomaly contributing to those pulsations. But it's not always that simple. It's not usually that slam dunk. We have pulsatile tinnitus that can not respond to any sort of neck compression or maneuvers, and some of those patients have a dehiscent superior canal. We did a study on this and published on it, where we looked at a group of patients that we'd operated on for a mastoid encephalocele and a spontaneous CSF leak, and we found that almost 31% of those had a radiographic dehiscence of the superior canal. Now, radiographic, I'm not saying that these patients have superior canal dehiscence syndrome, but they had a radiographic dehiscence. And why is that relevant? Well, I pushed this to our group. Our skull-based team just assumes everyone has a dehiscent superior canal, because those patients in our hands are usually surgical patients that need to have middle fossa dissection to address their leaks or the encephalocele. And the last thing you do is want to cause an iatrogenic injury to a dehiscent superior canal and give them a new problem, a vestibulopathy or a sensorineural loss. Speaking of hearing loss, these patients can present with a variety of hearing problems, whether it's a conductive hearing loss from mass effect of encephalocele over the ossicles, or because of effusions that could be either obstructive, post-obstructive fluid, or CSF. They can have sensorineural hearing loss. Sensorineural hearing loss that fluctuates, it's something that has been linked to intracranial pressures. I don't know how many of you have seen, but I certainly have seen patients with malfunctioning shunts, and they're being overdrained and come in their office, all kinds of not only vestibulars, but fluctuating hearing loss. Well, the opposite has a similar effect. So you will see patients with sensorineural loss that can fluctuate or just is progressive. Now, the rates of spontaneous CSF leaks are increasing. We know that our surgical practice is not really drying up. Even with GLP-1 use, they're still coming. We're still collecting CSF out of ears in our clinics. But one thing that was going to really help us in trying to tease out the patients that are perhaps true RIH versus not is that the patients who have spontaneous CSF leaks tend to be older. They tend to be in their 50s. Remember, true IIH patients tend to be younger women, but the group that we end up taking to the OR is usually an older group of individuals where papilledema is not necessarily present. So in summary, IIH is rising, and we are positioned in a space where we're going to probably come into contact with these patients and sometimes be the ones that lead the diagnosis. So we have to learn about these patients and try to tease them out between, oh, this is a migraine patient, or maybe there's something else going on that we really need to look into further.
All right. Is everybody hearing okay without a reverberation from this microphone? Okay, so we have our next question. At what intracranial pressure, using opening pressure measured in centimeters of water at lumbar puncture, is otologic function adversely affected? If y'all can start voting. The race between 20 and 25. 25 is winning. 30 is up there. Do I hear a 35? $5,000. I want to see that patient.
Millimeters.
All right, looks like 25 is in the lead with 20 and 30 kind of right behind. All right. So I'm going to talk about diagnosis and no disclosures. At what ICP is otologic function adversely affected? And here's the answer. We don't know. What we do know is that as the pressure increases, we get increasing progressive loss or reduction of vestibular function. So it's more of a spectrum rather than an absolute number. Our criteria that's been proposed for IIH, number 1 is papilledema, 2, headache, and elevated intracranial pressure. That was the dandy criterion. The other thing you had to do was exclude some other neurologic pathology, and they used pneumoencephalography back then in 1937. It was updated in 1985 using CAT scan to rule out intracranial pathology, and then in 2002 we got the Friedman criteria, which added MRI, again as a negative factor to exclude other pathologies. It also was the first criteria that actually put a number on it. It called 25 centimeters of water as the cutoff. However, even at that point, they recognized that some of these folks are less than 25, and if they've got the rest of the criteria, they might be probable IIH. Well, there's a problem with this, and it was recognized by a number of folks, is a lot of these folks have all these things, but they don't have papilledema. So in 2013, they came out with another set of criteria that say, well, you don't have to have papilledema, but you got to have a sixth nerve. Or you don't have to have papilledema or a sixth nerve, but you have to have these positive MRI findings to make the diagnosis of IIH. Now, what is missing from these criteria? I'm talking to a group of ear doctors, and the big thing that's missing is there's no mention of otologic manifestations. And we all know that it's important. As Esther just went through, there's all kinds of otologic manifestations. and they're not insignificant. When it comes to our evaluation of these folks, unfortunately, the testing is not real helpful, and it's because there's this progressive dysfunction. Probably the two tests I will say to you that are most helpful, number one is your audiogram. By the time you're up to 25 centimeters of water pressure, 2/3 of the patients have hearing loss. Unfortunately, the patterns are varied, as Esther mentioned. But the kind of classic one is that upsloping pattern of hearing loss that can fluctuate. Second, and probably more helpful, is vent testing. As we get up higher in pressures, you're going to see reduction in the amplitude of the response. For your vent testing, you're going to see delayed latencies, and you're going to see a tuning frequency change. By the time you get to 25 centimeters of water, 20% will have absent vents, 80% will have reduction in vents. And the nice thing about it, though, is it is at least partially reversible if you lower their pressure. Imaging, I'm not going to go through imaging because we have our radiologists here to go through things, but the important thing I want to share with you is it does not show pressure. It shows anatomic changes that are suggestive of increased pressure at some point in time. So that even after you lower their pressure, you may still have these persistent changes on the scan. The other important thing is you want to check to make sure they don't have cerebellar ectopia or Chiari before you do an LP on these folks. Next, we get to actual measurement of intracranial pressure. And there's a number of different ways of looking at non-invasively. In my practice, we've used the tympanic membrane displacement analyzer, which is also called the Marchbanks device, and I'll talk about that in a minute. But most of you guys are going to use lumbar puncture. And the big thing to remember with that is it tells you what the intracranial pressure is at that point in time. It's a snapshot. It doesn't tell you what it is yesterday, doesn't tell you what it is tomorrow, or even 5 minutes from now. Briefly, the Marchbanks device is based on measuring pulse pressures and the acoustic reflex response, with the idea that intracranial pressure is transmitted to the back of the stapes. A positive deflection on your acoustic reflex represents lower normal pressure. A negative deflection suggests high pressure. We've been using this since 2003. I've done it in over 3,000 patients. Because it's non-invasive, it's not a big deal to use. We've done about 1,000 LPs or so to correlate pressures. It requires a normal middle ear and a normal acoustic reflex at 1,000 hertz. The results do correlate with the intracranial pressure, and it's got pretty good sensitivity and specificity. It gets even better if you exclude superior canal dehiscence and other third mobile window disorders. This led to a study we did with NASA that approved its use in the International Space Station, which is now being used. Before anybody asks, I'll tell you there's no CPT code for it, and you don't get any reimbursement. So it's a freebie. Next is lumbar puncture, which I think is going to be the more definitive help in making this diagnosis. I would urge you, when you do lumbar punctures on these folks, you do them both awake and asleep. The way we do it is I have an anesthesiologist who does the LP for me, and they sedate them, and then they wake them up, and we get an awake and asleep measurement. Then drain them down to a low normal pressure, like 12 or 13, and you want to assess their symptoms before the LP and shortly afterwards. And I say shortly afterwards because you've got a maybe 8 to 72 hour window before that pressure is back up to where it was to begin with. There are certain symptoms that will get better with the LP, and I've got them listed here: oral fullness, pulsatile tinnitus, that rocking sensation, low pitch hearing will improve, and the headaches and head pressure will improve. These other symptoms won't necessarily improve, especially not early on, so don't expect inbound tinnitus, that high-pitched tinnitus, vertigo, hyperacusis, or migraine to get better. This is an article that my colleague Bulent Mamakoglu and I wrote, basically talking about these folks that don't have papilledema, they don't fit the Friedman criteria, yet they've got otologic symptoms and they get better when you lower their intracranial pressure. We term the condition mildly elevated intracranial pressure. for this group of patients that are essentially being ignored today. And I'm going to end with a case. This is a 57-year-old gentleman who I saw in 2011 with new onset progressive fluctuating right hearing loss and long-standing left profound hearing loss. He had bilateral aural fullness, pulsatile tinnitus, history of episodic vertigo in the past that had since resolved, dizziness, that rocking, shifting sensation. He had no headache, no papilledema. He had sleep apnea treated for many years. The TMD device suggested his intracranial pressure was elevated. MRI, MRA, MRV was normal, although I have to admit in 2011 I wasn't looking for all the subtle changes back then, so it may have been there. CT scan was essentially normal other than thinning of the left posterior canal, but nothing abnormal on the right side. Empirically started treating him with acetazolamide and diazide with some mild improvement. So we did a number of LPs on this guy, and these are, keep in mind, these are LPs done while he's under treatment. And if you look on the left-hand side, those numbers are not impressive. 18, 14, 19, 13, those are all normal, okay? But when we'd allow him to go to sleep, his pressures would shoot up in a matter of a few seconds into the stratosphere. And draining off his CSF would make his hearing get better. We eventually referred him for a shunt where his hearing stabilized, his dizziness went away, etc. In conclusion, IIH diagnostic criteria ignores otologic manifestations. 2, absence of papilledema does not exclude the diagnosis of intracranial pressure elevation. The diagnosis of otologic increased pressure, or as we call mildly elevated intracranial pressure, I think relies on clinical imaging findings suggestive of increased pressure, and then a lumbar puncture with drainage that allows for resolution of the symptoms that are temporarily resolved. And that's what I got for you guys.
Oh, so there's another question posted here. Was the prevalence of elevated ICP in temporal bone spontaneous CSF leak patients after successful repair? Oh, go ahead. Okay, yeah, let's have an answer. 30 responses.
You might have to wait till the next talk to get the answer.
Yeah, we'll let that be. All right, should I go forward here? Can we please bring my slides up?
Just hit the green button. There you go.
All right, here we go. I do want to thank Dr. Nelson and the Society for my opportunity to speak today. It's a real honor for me to be a part of this meeting. And so what I would like to do is really identify those intracranial findings which reflect pressure, not necessarily IIH, but pressure in general. And with attention to the skull base and temporal bone with some case examples, which we've already seen some nice examples of, in the hope that when you look at these structures, a patient presents with you concern for IIH, you can really critically assess that patient and their imaging and come up with your own decision. So that said, do you think this patient has intracranial hypertension? I'll let that dwell and we'll come back to it. So when I think of these patients, I think of these in 3 groups. They're either hypotensive, normotensive, or hypertensive. And we already know that we've already heard that 25 centimeters of water on LP is what we would identify as those being hypertensive. Although before I send somebody to that invasive procedure, I want to be pretty sure that I'm going to see an elevated pressure. So I like to think about a few things. First, communicating in potential stasis. So which of those spaces do communicate with the subarachnoid space that can be dilated, such as the optic nerves? They can get tortuous, they can be dilated. The cisterns, such as the trigeminal cistern, the oculomotor cistern, I can see those dilated as well. Although I have seen trigeminal cisterns narrowed when that dural reflection from the middle cranial fossa comes over and narrows it. Arachnoid granulations can expand. And the subdural space, we don't think about the subdural space much in intracranial hypertension, but in hypotension it can expand and result in subdural hygromas. So Next, I think about short-term compliance structures. So which of those structures can change with intracranial pressure, such as the diaphragm cell. In hypotension, it can rise, and hypertension, it becomes concave, as we know. In venous sinuses, I do want to spend a little bit of time on that. This is a 2016 paper from Mayo Clinic Rochester that identified multiple findings on MRI that can be indicative of intracranial pressure, and they found the most sensitive finding was transverse sinus stenosis, bilateral in 83% of their study population. When they went to MRV, they showed a bilateral stenosis of greater than 50% in 94% of their patients as compared to 3% of controls. So if we're trying to identify those which may have intracranial pressure elevation, that's a good thing to look at. And we know in our interventional colleagues, and I'll kind of defer this to Dr. Bohnstedt later, if they can identify elevated gradients across that stenosis, those patients are more likely to have a higher opening pressure. And then finally, long-term remodeling. This is what was just alluded to earlier. When we see this remodeling, that patient may have intracranial hypertension or may have historically had intracranial hypertension, but we look for cellular expansion and remodeling of that skull base. So let's look at some images. Here's a patient that's normotensive. We see a nice flat pituitary gland. If I turn on contrast here and move that basilar artery out of the way, that prepontine cistern is nice and spacious. We have a nice curved margin of the anterior pons. When I go out and look at this transverse sinus, it kind of looks like a pizza pie, right? It has a nice triangular appearance. It's not outwardly bowed or inwardly narrowed. Here's a patient with intracranial hypotension. Look at that superior pituitary margin. This patient does not have an adenoma. When I look at that brainstem and turn on contrast here, we can see that prepontine cistern's narrowed. The pons is flattened. We see some downward displacement of that brainstem. And that reminds me, these patients, if they have a CSF leak, it's going to be below that craniocervical junction. It's a good way to think of it, especially for our trainees as well, is where the CSF leak in intracranial hypertension is typically along the skull base. We can see that downward motion in the axial plane as well, with basal cistern narrowing, some ambient cistern deformity, some midbrain deformity. And if I go out into the transverse sinus on this patient, it's abnormally expanded. It's outwardly bowed, as that the venous pressure outweighs the intracranial pressure. And we can see dural thickening in these patients too, as that subdural space is starting to widen, and that's accentuated by the post-contrast imaging. So if I put these two together, you can compare and contrast them. But what about intracranial hypertension? Right, we've already talked about a concave cella, but I want to see some remodeling too. And we have to think about the age of the patient as well, right? So this 32-year-old female, her cellular fossa is extremely expanded. Here's a 37-year-old female with similar findings. I brought the CT up here just to show the size of that cella as compared to the sphenoid sinus and the clivus. It really is expanded. Optic nerves become distended. We talk about them being tortuous as well, and as this continues, those patients can get papillary inversion. So if I see this on exam, I see this widened optic nerve sheath complex. We see the papillary inversion here. We give contrast. We see enhancement there. This is a patient that's likely going to have papilledema on exam, and we can actually see diffusion signal abnormality in those optic papillae as well. Venous sinuses, and so this is the slide that Dr. Nelson was worried is going to take me years to get through, but if you see here on the left, we have a hypoplastic left transverse sinus that's additionally stenotic. If we go to the right here, this looks like a pretty normal transverse sinus until we get to the anastenotic vena levae, and as that comes off, we see severe stenosis. This patient also went on to MRV, so we have a nice 3D representation of those same findings showing the hypoplasia over here, stenosis, and then stenosis here distally on the right, and that can be a treatment target. One thing I also look at is just the skull base in general. When I see all of the scalloping along the skull base, I'm very worried. That's an indication for me to go look at that cellular fossa, to go look at those transverse sinuses. Even this patient's foramen ovale is asymmetrically widened on that side. Here's a patient that has signs of intracranial hypertension, and she had an anterior cephalocele. She had a CSF leak nasally, and we can see a cephalocele here in her right sphenoid sinus. Here it is on coronal. And if we go to their T2 weighted coronal image, you can see a portion of that temporal lobe coming right under the sphenoid sinus, right? She has dilated optic nerve sheath complexes and a big and large cella. So if we go back, these are the patients, and we've seen some great examples of this already. Here's a 52-year-old male along posteriorly that has a large tegmen defect along the tegmen tympani, making its way back to the tegmenus testodium along that adducens antrum. So we can add in intracranial hypertension here and look at these three. Hypotension, diaphragm cell is up. Normotensive, that's relatively flat. Hypertension, not only concave, but in widened cellular fossa. And we can see that transverse sinus is stenotic in this patient as compared to distended in the hypotensive case. Look at just a couple of examples. Here's a 38-year-old female who came in with conductive hearing loss and retrotympanic fluid identified. You can see she has an enlarged cellular fossa with a concave. Here's her optic nerve sheath complexes, a little bit of flattening. You can see that cella again. Here's a left transverse sinus stenosis. Here's her right transverse sinus stenosis. And we look at her tegmen, it's markedly dehiscent. Likely have a cephalocele here with complete fullness or pacification of that middle ear cavity. Tympanic membrane is outwardly bowed. And this patient had an MRIAC that actually shows that dural margin going through that defect. And they actually went on to cysternography, where we put IsoView 300M in their subarachnoid space, as well as a radiotracer. And you can see there's frank extravasation of contrast into that middle ear cavity and out into the external auditory canal. When we took this pledget that we packed and put it in our well counter, the background counts were 8 as opposed to 300,000 on that right ear pledget, so positive CSF leak, right? She went on to middle cranial fossa tegment repair. Here's another case. This patient had a fovea ethmoidalis cephalocele repaired and came in with concern for additional CSF leak. And here are her MRI images. We have an enlarged cella and partially empty. We see bilaterally. We have transverse sinus stenosis on the same image. Here's her T2 weighted coronal image. We have an enlarged cellular fossa, enlarged trigeminal cistern. She probably has a small cephalocele here along, just kind of lateral to that foramen ovale. Here along her right tegmen, she has a small cephalocele medially and along the epitympanum. Here's her CTIC. You can just see about the size of that cellular fossa in this patient. So this is no doubt I'd be worried about either prior or ongoing intracranial hypertension. And you can see here that she has that cephalocele just medial in the epitympanum, coming along where we expect the geniculate ganglion to be. She has that bilateral dehiscence. She went on to bilateral middle cranial fossa repair. So another good lesson. She's had an anterior cranial fossa repair and bilateral middle cranial fossa. If you see one, look for the other, right? So in summary, does this patient have intracranial hypertension? Likely not. If you look at all this patient, was 94 years old actually, but they have an empty cell. It's not abnormally expanded with relation to the adjacent structures, and their transverse sigmoid junction is nice and expanded. So hopefully with that, you can take those features that we went to and really think about those patients that you're seeing and identify findings that might indicate that they've either had prior or ongoing intracranial
So this is a post-lecture test now. So we had the slides mixed up. We'll see if you guys get this one correct. Yeah, so as we mentioned, transverse sinus stenosis is one of the more specific findings for ICP elevation. So back to the previous question was for my talk, which is what's the rate of intracranial pressure over 25 in spontaneous leak patients? And it was pretty across the board, smattering of what was answered. Most common was 32%. So I'll focus mainly on spontaneous leaks, which we've seen more and more in our practices. Obviously, we have a problem in this country with obesity. And in our practices, particularly in the Midwest and the South, we have a problem with spontaneous leaks. And I've coined this term the American obesaleak epidemic. I think what we understand as far as the pathophysiology of this condition is we know there's certain things that are associated with it. Of course, we know that obesity is associated with this problem. We also know that there's skull thinning that happens in these patients. We know that there's things that are associated with obesity that are probably related or causal of the skull thinning, because just being obese does not thin out the skull. And so a couple things is sleep apnea. We've shown in our research that sleep apnea itself thins out the skull, as does intracranial hypertension. And so to answer our question, we did a study where we did LPs and sleep apnea testing on patients with spontaneous leak. So we did LPs 6 weeks after repair, and no other sites were leaking, so we assumed that they were at their baseline. We had 39 patients. Surprisingly, the mean opening pressure was only 22.3 centimeters of water, and only 1 out of 3 patients had an elevated ICP over 25. So kind of surprising because we think that ICP is the main problem with these patients. 2 separate studies, we showed that in lab sleep studies, the patients, 83 to 93% of these patients have sleep apnea. And I'll show you data to suggest, and Dr. Gianoli showed this before, but ICPs spike with obstructive sleep apnea episodes. So the mean AHI in these patients is somewhere between 20 and 25 events per hour, so that's basically moderate to severe OSA. Interestingly, we found in our data on the right, this graph shows a correlation between the AHI index and the patient's lumbar puncture. Because no one wants to sign up for a lumbar puncture. So who can we sort of decide really needs to have this performed? And these would be the patients with an AHI. So you get a sleep study first. If their AHI is over 18, or they have a multifocal leak, meaning bilateral temporal bone or nasal and temporal bone, and particularly in women, then those patients are the ones you want to get a lumbar puncture. Our data is also supported by a recent publication in Neurosurgery where they looked at patients that had both anterior and lateral leaks, and across the board, both of those conditions, they found a similar rate of elevated pressure of only 32%. I say only 32, but we think that that's going to be much higher, but it's only 1 in 3 patients. So this shows a graph back from the 1980s, which shows how intracranial pressure spikes during an apneic episode normally are around low 20s. The ICP can spike up to 70 centimeters of water in every apneic event. So if you think of a patient having anywhere from 20 to 60 of those events per hour, that sort of cyclical spiking is theorized to thin out the skull. So I think what we have is a baseline mildly elevated ICP across the board, in addition to OSA, which causes these intracranial spikes, which leads to the thinning and ultimately the leaking. And so we have to target both of these, intracranial pressure and OSA and obesity, to be able to treat these patients. So I'll briefly just talk about Diamox. We covered this about 1.5 years ago. Many of you know this data, but Diamox can be used to lower the intracranial pressure. Usually it takes quite a bit of a high dose. I don't know if anybody does that yourself or you work with a neurologist. I tend to probably err on the side of being cautious with only doing 250 or 500 twice a day. Problem is that you get higher doses. People don't tolerate it due to paresthesias and other symptoms. Things I think you should understand is that it's contraindicated in patients that have a life-threatening sulfa allergy, or particularly in patients with COPD, which is not common in this patient population, but that causes a metabolic acidosis, increases respiration, and can be a problem for those patients. In the vision literature, they usually need pretty high doses, 3 to 4 grams per day to reduce papilledema. What I want to spend a little time on is this idea of GLP-1s. And you see these names up here, but we see several that we've heard in the literature, but mainly I'll focus on Zepbound, which is a combination of 2 separate compounds, the glucose-dependent insulinotropic polypeptide and GLP-1 or glucagon-like peptide agonist. This is called Zepbound or Mounjaro. And I'll talk about the clinical trials that have shown improvement in weight and also in OSA. Because I think what we can do with these medications potentially is they could treat weight, they can treat sleep apnea, and they may even be able to treat CSF pressure by CSF production, because GLP-1 receptors are actually expressed in the choroid plexus. So this is from the SURMOUNT-4 trial. Basically, this trial was a randomized withdrawal clinical trial with Mounjaro. And you can see on the graph on the right that all the patients were started, and after 36 weeks, they were randomized to either withdraw the medication or continue the medication. You can see an excellent weight loss, 20% of their weight loss, and then after they stop, they gained back about 60% of the weight. So this suggests that they need to maintain this medication to maintain the weight loss. There's an additional study, the SURMOUNT-OSA trial, using Mounjaro versus placebo. The patient population was similar to our CSF leak patients. BMI was 39, average AHI was 50. And what they found was there's, again, 20% weight loss. They actually saw a 55% improvement in AHI. So if you say, well, they started at 50 and they get down to 25, that's pretty good, but they may still have OSA. But 42% went to mild or no OSA. And so the FDA has now approved Zepbound for moderate to severe OSA. We should be cautious with these medications because in the trials, all of these patients were encouraged, obviously, to complete the study. But in real-life situations, we know that after a year, only 40% of the patients are still taking the medication because of side effects, usually GI-related side effects. And obviously, when they stop the medication, the weight comes back. And this was a study from a laboratory with animals, basically shows that a GLP-1 receptor agonist pretty quickly lowers the pressure inside the head of rats. And so potentially, this could be used in humans. There's no good data that I could find that shows that this has been done in humans to measure ICP over time. But potentially, this would be the third way we could treat intracranial hypertension. So now I'm going to move from the objective data to my anecdotal data on my one patient. So this was a 52-year-old patient who came to me a year ago. She had OSA for 15 years. BMI was 47. You can see on the left side, she has a large tegment defect, encephalocele, fluid in the ear, CSF leak. On the right side, she has superior canal dehiscence and that encephalocele, which was not leaking. So we took her for a left middle fossa craniotomy and repair. And then she started Ozempic at 0.5 milligrams every day for the last year. She got a repeat sleep study which showed her AHI was 87, which despite her taking that, her AHI was still elevated. Her LP was only 18, and her weight loss was actually not very significant, despite continuing the medication. And then she recently presented to me a month ago with right ear fullness. As you can see on the right ear, we now have fluid in the ear and the mastoid, still the encephalocele and the superior canal dehiscence. And the left side with the bone cement looks aerated and stable. So despite her being on this medication, I guess she still was leaking. So this is my sort of caution that maybe this sounds great, but it may not be the magic trick. More study is needed. So I'm going to hand it off to Dr. Bohnstedt. Thank you.
Well, now I'm going to provide all the answers so that we don't have to do anything invasive. Not really. We'll talk a little bit about the radiographic findings, the physiologic measurements that I and a lot of others use to determine if there's a benefit to stenting. How do we stent endovascularly? And then when that fails, what are the neurosurgeon's treatments for this? Really, when I'm thinking about IIH patients, any type of imaging of the head, it gives me some information that I can use. The CTs show me the ventricles. I do think that typically patients with IIH in my practice have small ventricles, and if they're large ventricles, we're looking at some other type of diagnosis. The CTV or the CTA, as was shown earlier, will frequently show those changes in the transverse sigmoid sinuses, and the superior sagittal sinus will even show some stenosis at times. MRI, again, I'm looking at the ventricles, but also looking to rule out any other type of pathology that's going on. MRVs are valuable more in the pre-stent situation. CTVs are better in the post-stent situation to evaluate the patency, to make sure that there's no restenosis due to intimal hyperplasia. Generally, we found 50% reduction in the size of these sinuses to be predictive of the elevated ICP, but what does that really mean, 50% compared to where? I typically think it's upstream and closer to the superior sagittal sinus for your larger measurement, and then as it gets narrower, as opposed to measuring that area of narrowing down to the sigmoid. Usually patients that respond better to stenting and are beneficial for this, and I think follow more of the IIH pathology, will have at least one side where the stenosis is no longer than a length of 2 centimeters. If it's a very long length, there's probably something else going on, and they're also not as responsive to the stenting. So I have 3. This is the same patient where you'll be able to see the stenosis, as we mentioned before, Dr. Graner. And really this happens right at the transverse sigmoid junction. You don't always see the stenosis the whole way along, but you're looking right at that edge. Right, and here, the most common place where we'll wind up seeing. And then on the coronals as it comes around. And you'll notice not all of these are a concentric narrowing where it comes down to a focal spot, but sometimes there's areas within those that you'll see little lines, and I think that's scar tissue that's frequently in there. And sometimes that previous pathology may have been a clot that was in there, and now we've formed scar tissue that's left behind. I think the presentation and the behavior with IIH is very similar in that situation, although it's a little bit different. And then on this are just the reconstructions of the MRVs. Kind of went through. Okay. So the pathophysiology, the brain is bathed in the cerebral spinal fluid, and it's necessary to get out the toxins and to keep everything moving. It's turned over 3 times a day in terms of that fluid, so it's easy for it to build up in there. It's produced by the choroid plexus, it's reabsorbed by those arachnoid granulations. Those arachnoid granulations all exist proximal in the venous system to that transverse sigmoid junction. So if you have that stenosis in that area, then all of the areas that are supposed to reabsorb the CSF are going to be impeded. When we look at the pressures, which seems to be the most predictive factor for if a venous sinus stent is going to work and be able to help things out, we have much lower pressures in the vena cava and higher pressures, and these are in normal patients, in the superior sagittal sinus. So it makes sense that the venous flow goes from a bit higher pressure to a lower pressure system. And then the CSF pressure, if you think about it in the range of 7 to 15 being normal, has to overcome the pressures that would be within the vein in those corresponding areas. It's not atypical to have asymmetric venous sinuses. The right is typically dominant and usually larger, so you will see a normal anatomical variance with narrowing on the left. But then if there's a focal spot on the right that's more narrow, that's what leads to this obstruction and the increase in the pressure gradient. There have been some studies looking at the fluid dynamics through the veins, and what we find is there's turbulent flow across that area of stenosis, and especially right after the stenosis where the pressure is lower. And it's felt that perhaps some of this turbulent flow is what's causing the tinnitus component or the otologic symptoms that go along with IIH. Fortunately, when we're able to open up that area of focal narrowing, we take care of that turbulent flow. The pressures are similar across this. There's still usually a small gradient, as is normal in physiology. Specifically, individuals that have a gradient of 8 when they're awake across this seem to benefit the most. When patients are asleep for the evaluation of the pressure gradients, as in pediatrics, we lower that gradient and look at pressure gradient of 4, and the reason for that is a positive pressure ventilation. So this is a late phase angiogram where you can see some stenosis or thinning here on the lateral aspect. And here's your focal stenosis on the AP view. As we measured the pressures, and this time it's with a catheter, as you can see here in the middle, some use a fiber optic wire to measure pressures. There's a normal decrease in the pressure as you go through, but there's a much greater drop in pressure across the transverse sigmoid junction, and schematics representing that stenosis. And then here's an example where the stent is in, and we have significant increase in flow, and the pressure is normalized intracranially. It was a gradient of 2 after this across that junction. That's the start and the end of the stent. So is venous sinus stenting the answer to everything? No. 30% permanently improve and feel great afterwards. Another 60% do well, at least initially, and have recurrence of symptoms. And 5 to 7% go on to still have a surgical procedure that may include ventriculoperitoneal or lumboperitoneal shunting. Of those that have improvement, that have recurrent symptoms later, there's still an improvement in the ICP, but we know headaches are multifactorial, and most of the symptoms that were in the surgical group that led to another procedure was due to headaches. Risks of stents, they're fairly low, even though many still have a form of headache, at least in the first 2 to 3 days afterwards. There can be access site problems or contrast reactions. Major complications with hemorrhages are rare, but we'd be remiss if we didn't point out that not everything's flawless. And then these are just the surgical options that can help with reducing the intracranial pressure. And incidentally, we have found frequently, even when we shunt people, that their venous sinus stenosis improves if it was simply due to the pressure alone.
Thank you very much. So we'll open the floor up to questions. Where's Michael?
This is Michael Seidman from Orlando. Question I have, it's very common that I see the radiologic funding, and we send them to neuro-ophthalmology, and they say there's no papilledema, and then you're stuck. You don't want to send the patient for an LP because now they're saying it's a normal exam. And so, I mean, I'm curious what everyone does in a situation like this, where there are clear signs of it on imaging, but the neuro-ophthalmology exam is normal.
I guess I'll start. I have two options for those patients. One, either I empirically just start treating them with Diamox, or I will get the LP myself. I mean, I've seen enough of them where they don't have papilledema. As a matter of fact, I would say less than 10% of the patients I see have papilledema, but they get immense relief from lowering ICP.
So if you do the LP and then the pressure goes down and they feel relief, then what? Then you send them to neurosurgery, or
No.
you just continue Diamox?
I'd put them on Diamox. Sometimes I use regular Diurex, and sometimes I mix the two. And I do a progressive, exactly like Rick laid out. I do a progressive titration with them. Some folks do well with lower doses, and some you have to go up to as much as 4 grams.
Thank you.
I think in neurology, they really just treat symptoms. So if there's no headaches, then they aren't interested in treating just an MRI finding. So I think it's probably also based on headaches or other symptoms that they're having.
John Lassick, Wichita, Kansas. For the obese patients after repair, do you start them on the GLP-1s? Are you doing that? And if not, how soon do you allow them to use their CPAP?
Yeah, I don't prescribe GLP-1s. It'd be nice to do a study, maybe even a multi-institutional study on these patients. But as far as CPAP, so you saw on the repair with the bone cement, it's a very robust repair. So we get a CT at night, right after the surgery, ensure that it's sealed, because you can see it on the scan. And if it's sealed, then we start them right away. We published our results that we have no pneumocephalus complications.
And that's fixed from above?
Yeah, middle fossa.
Yeah, hi, Mike again. Which came first, the chicken or the egg? Is it the stenosis that causes the hypertension, or is it the hypertension that causes the stenosis? So where do you break the cycle?
So we've spent a lot of time thinking about this. And I think there's something that initially elevates the ICP in the vast majority of cases that don't have a clot or something like that. There's something that drives the pressure up. Maybe they had a viral infection, maybe they had meningitis, something like that. And that starts the process. And then subsequently it becomes a cycle. It's a feed-forward cycle because if you can't reabsorb the CSF, the pressure in the head goes up, the stenosis gets worse. So it's hard to know. In kids, we found that if you can temporarily just break it by doing a venoplasty, and you don't even have to put a stent in. And over the course of time, everything normalizes and looks fine. There's still some that you have to stent. In adults, it's less likely. I think the pathology is a little bit more ingrained. In the chronic, elevated pressure lasts longer. But I think there's something separate than the venous stenosis that starts the elevation of pressure, but then it feeds forward thereafter.
And then if you relieve that stenosis or shunt, does it eventually get better?
The ICP?
Correct.
It does.
Yeah, okay. By the way, congratulations. This is a great forum. Thank you.
Yeah, Hamed Sajadi from Stanford. Excellent talks and really a ton of good information. Just a comment, there's some good information in the ophthalmology literature about OCT. And if you ask for OCT of the retina and OCT of the optic nerve and they haven't compare them. Also, there's some published literature, again in ophthalmology, that a very low vitamin D and elevated vitamin A is associated with intracranial hypertension. So maybe an underlying cause of the whole problem.
Yeah, thank you for that. That brings up a good point. The neuroophthalmologist using OCT can differentiate between patients who may not have active papilledema, but they can actually see if they've previously had it. And it gives you a clue in terms of medical management after a surgical repair. And we follow those patients more closely.
So we're going to start taking the online questions, and the first one we have is, what are the distinguishing features between IIH and NPH? And I'm going to defer to our radiologist.
No, they're
here.
definitely two different processes, but definitely deal with pressure. So as it's mentioned, it's normal pressure hydrocephalus, and largely in that, when I suggest that, I'm looking at the ventricles. And you'd mentioned that the ventricles are smaller and intracranial hypertension. That's something we relied upon a lot before. Oh, could nobody hear me? There we go. Sorry. So in NPH, those ventricles are enlarged. We see the sylvian fissures getting expanded. We see the parafalcine sulci getting narrowed. We refer to that as a Desch pattern, where it doesn't show those typical increased intracranial pressure findings, which I discussed, kind of along the skull base. And so they end up being two kind of different entities, even though they both deal with CSF resorption problems.
You know, the other thing from a clinical standpoint, they're very different.
Yeah.
The NPH patient has the triad of the magnetic gait, where they don't want to lift their feet off the floor. They kind of keep them and shuffle them. They have memory issues, kind of early dementia type of look. And the third is incontinence. So that's not what you see with IIH.
Yeah, agreed.
Second question we have is, why do stenoses greater than 2 centimeters do worse? Is it a procedural or equipment limitation, or is it a physiologic issue?
I think we're probably dealing with a different type of pathology is what it really is. We have stents that are up to 8 centimeters long that we can place that are tapered, and we can get those in those areas. But usually when the vessel is small for a much longer distance than that, it's usually a different type of pathology that's not going to respond as well to the device that's going on. In other words, if it's a smaller sinus to start, and that's usually where we see a stenosis over a longer distance, and then we go and we try to open that up with a stent, you end up actually stretching the dura and tearing it a little bit, it becomes less physiologic. The physiologic stenosis is usually a shorter segment, and that's why it responds better. So I think the reason it's different is it's a different pathology, I think, that's going on.
All right, so the boss tells me there's only time enough for one more question. There is at least one paper showing that topiramate may be better than acetazolamide at lowering ICP. Does anyone have experience with that? I can tell you from myself, I don't use Topamax very often, but I find it's even less tolerable to a lot of folks when you get to the higher levels than acetazolamide. I don't know if you guys have any experience with it.
I don't use it.
We use it a fair amount. I'd have to agree. I'd go with Diamox many times over before I would run with topiramate. The ability to titrate it up and down is a lot better. Tolerance is different, but when you're dealing with the headache side of complications, topiramate does do a lot better with the headache side of things as opposed to the IIH, the elevated ICP.
Yeah, I have a lot of experience with topiramate and headache management, and I would echo that. So if headache is a feature, then the sodium channel blocker is also very effective for headache control, which can really help these patients. And they can tolerate it up to really high doses, sometimes as high as 150 milligrams twice a day.
Thank you very much for a really informative panel.